Okay, I'm going to go ahead and get started. Our agenda for today, we will do a quick report out with updates on your PDSA, um, any wins or opportunities that you have, or any questions that are going on. I'll kind of go through the list of practices like we normally do, and you can take a few moments to report out. I know that there are a few people that aren't here today because they're on vacation, so that's all right. And then I have a few reminders. We'll go do a little bit of data, and then Dr. Gittleman is going to present on injury prevention today, which is great. So starting with our practices, Dr. Bennett, would you like to start? Oh, I think you're muted.
There we go.
There you go.
How's that?
Perfect.
Hi, I'm John Bennett. This is my first meeting. I just joined this situation, and yeah, what else can I say?
How has data collection been going?
Okay. We're still trying to find our way with everything. But I mean, the data collection part is fine. It's just the figuring out the format for the reporting and all that. That's there's a bit of a learning curve, but we're getting there.
All right, well, let us know if there's anything that we can help with.
Oh yeah, well, we will. So
Great, thank you. All right, what about Kettering Physician Network Pediatrics, Alexis? She may not be on yet. Dr. Call?
Yes, hello. So for our data collection, we've had some staffing changes, especially the MAs that are working with me. So our process is that my MAs are distributing the screening, but we've had some changes. So I've had a revolving door on that. So not everybody has been up to speed in getting it. So we've been missing some patients because of that. So, but work in progress. So trying to remind them when I do see them that like it needs to be done. So. And then I think I'm using the slicer and dicer wrong incorrectly. So I will respond to your email.
No, I don't think.
I thought it was the number. The numbers were.
It's just because it included well visits.
I don't know.
No, it's okay. I think I know what happened, so I can help you fix it.
Okay, awesome.
Yes, great. Dr. Kumar? Not on yet. All right, Dr. Obedo? She may not be on yet either. Dr. Swartz? Dr. Swartz, are you on for Cleveland Clinic? He may have had to step out for a moment. Brooke?
Hello.
Hi.
Dr. Eberhardt will be joining me here shortly as well.
Oh, great.
Things are going well. Data collection's moving smoothly. We actually embedded these into Athena's order set. So it's a good reminder for clinical staff to make sure patients are filling out these questionnaires.
That's great. Was it pretty easy for you all to do that?
Yes, we've used it in the past for some other QI projects that we've done and just different quality things that we've implemented. So making it as an order set and embedding it into all of our well visits that meet that criteria, it automatically shows up. We have everything barcoded. So it's going really well.
That's great. That's great news. Thank you for sharing that.
You're welcome.
Wonderful. Dr. Adams? I don't think she's on yet. Dr. Inez Cubas Roland?
I'm here. Hi.
Hi, would you like to give your update?
So in my clinic, one of the problems will be a volume, but wise, I try to do the questionnaires with me, or one of my students or residents are doing rotation with me,
Mhm.
and PAs as well. So yeah, I could say that the overall health questionnaires are more friendly in
Mhm.
terms of the other questionnaire, social determinants. We
Mhm.
have template some questionnaires that we use as well. And since we have more availability to talk about these topics with mothers, they're more open to maybe to talk about it. So we can
Mhm.
identify more social determinants and we can refer them more often.
That's
Yeah.
great.
Yeah.
That's
So-
great. And I'm mailing you out new resources today.
Uh-huh. Okay. Thank you.
You're welcome.
Mhm.
Dr. Vargo? I think you're muted, Dr. Vargo.
Can you hear me now?
Yeah. And I know you
Okay.
are switching EMR systems.
We went to Epic beginning of March, so we've had a kind of a glitch there, but
Mhm.
the oral health screening has been very good. I think those questions are easy to ask, and we've made a lot more referrals with that. So
Great.
I'm expecting that will go even better. We're doing developmental ASQ at 30 months, and we just need to get those out a little bit more. We do the earlier age ones, but we also have had some staffing issues, so I think it'll improve.
Great. That sounds great. And if you need anything, need any help with Epic as you're transitioning with pulling data or anything like that, please let us know.
Oh, excellent. Thank you.
Yeah, of course. Let's see. Dr. Obeta, I know you just joined, but would you like to give a report out on how things are going?
I see. I'm sorry, my video is not working right now. I'm trying
It's
to get it
okay.
started. But so things are going well. In terms of the ASQ, the developmental screening, which I'm doing. So I know the AAP recommends it at certain specific months, like 9 months, 15 months, 30 months, I believe. But what we found out in our practice was that doing it at those certain months, they end up leaving some people out because some people come in and they're 12 months, but they've never had a 9-month screening. So what we ended up doing is from 2 months through to 6 years, no, through to 5 years. Everybody who comes in for a well child screen gets an ASQ screening done. So that way we don't forget anybody, and then the medical staff don't say, oh, he's not 9 months old, so we didn't do it. So basically everybody who comes in for a well child from 2 months to 60 months gets a well child, gets an ASQ screening done. In terms of the other QI project, which is the fluoride vanish, the oral health, we've been doing that for a while. That is going well. We actually are in the process of getting dental kits, like little kits with like a toothbrush, a toothpaste to give to kids when they're coming for their visit. But this we do from a year. It's meant to be from 6 months, but usually we end up doing it from a year through to 6 years of age, because usually between 6 and a year, they might just have 2 or 3 teeth or 1 or none at all. So usually between 1 and 6, we give them like a little dental kit to help them as well. And then we built into our templates, we built in the oral health questionnaires. Like, so we ask, do you have a dental home? Where's your dental home? How many times do you brush your teeth? Or do you brush your teeth twice a day? Do you use fluoride toothpaste, or do you use bottled water or tap water? So we're trying to ascertain if they have fluoride exposure. And we found out that quite a lot of the parents will come in and they don't realize that they could actually use fluoride toothpaste. A lot of the time they're still using the non-fluoride toothpaste. So that was really enlightening to me.
Yeah.
That they didn't realize that they could use the fluoride toothpaste. So that goes well. And then we do the fluoride vanish in the office. So if they haven't, so there's certain criteria. Like, so part of the questionnaires we ask them, if they don't have a dental home, or if they haven't had fluoride vanish in the last 6 months, or if they snack in between meals, or they drink juice, then we apply the fluoride varnish in the office. And then we actually we're taking part in like it's like a medical dental integration project. So we actually have a dental practice. And so we refer the patients that need a dental home to the dental practice, and then we'll keep a track of the referral.
That's great. You all have made a ton of progress. That's wonderful.
Amazing.
Yeah, that's great. Wonderful. Is there anyone that I missed? Okay, great. Just a few reminders, completing your first PDSA worksheet with your results and start thinking about your second PDSA. And then as far as data overview, we're doing really well. Baseline was at 23%. As far as screening, for the categories, this isn't for specific, I haven't broken it up by categories yet, and I'm going to, but this is just for screening in general for both of the chosen areas. We were at 82% the first month, 93% the second month, and then we're at 87% this month. So we're really up there with screening, screening kids that are eligible for screening. So that's great, and we're doing great. And then we'll have individual data sent out this week. And then Dr. Gittleman, I can pass it over to you.
All right, thank you.
Thank you.
So I think I have, my name is Mike Gittleman. I'm an ER physician at Cincinnati Children's, and I run a couple of, as medical director, a couple of the programs for the Ohio AAP. I know at least half of you on here, and it was nice to see everyone on Friday at our spring education meeting. If you didn't make it, hopefully you can make the next one, because the meetings are always invigorating and fun to go to. So I get to talk to you about injury prevention, something that is near and dear to my heart. And you're gonna hear me say next slide a lot, but that's just because it's a lot easier to have Alex change slides for me. So next slide. I have nothing to disclose. Next slide. So really what I want to get out of today is have you at least understand kind of the magnitude of the injury problem, understand some of the top injuries, and really get some understanding on how do we do this a little better with families. Next slide. So I'm sure all of you see this all the time. You watch local news and you see all these injuries that occur, and there'll be a teen shooting, there'll be a fire, there'll be a car crash, a child injured on a playground. And then you always hear them interview family members and they say, I wish I knew this. Why hasn't anyone ever told me? No one told me that this was going to happen. Next slide. So first, it's important to understand what an injury is. When I review abstracts for AAP's injury section, a lot of times, we'll see cell damage from some medicine or something like that. Yes, there is damage to your body, and it could be intentional or unintentional. And I think of it as from some external exposure. Another way to look at it is it's force, which equals mass times acceleration. So anything with a significant amount of force, okay, or a very small body, and anything that happens very quickly, those are the ones we have to be most concerned about. Next slide. But this is why I'm so passionate about injury prevention. When I went into pediatrics, my goal was to prevent morbidity and mortality to kids. I didn't want to see as many kids hurt. I didn't want to see as many deaths. And that's why we give immunizations. That's why we do anticipatory guidance. That's why we practice medicine. And if you take a look at it in the your top left corner, this is from the CDC. The #1 cause of death in kids, especially 1 to 44 years of age, unintentional injury. Then you start adding suicide, homicide in the bottom left corner. Close to 60% of deaths are the result of an injury. So if you look back and you say, okay, the lectures I received when I was younger, how proportionate were they to the morbidity and mortality to children? So I can tell you in my residency, I received 1 lecture about car seats. I had 5 lectures on meningitis, 6 lectures on pertussis, pneumonia, all the infectious diseases. I didn't learn a lot about injury prevention, yet I'm supposed to counsel and teach about it. Now, I will tell you, if you look over time, we have had an increase in the percent of deaths due to injury. Well, why is that? Immunizations work. We found other ways to prevent deaths we haven't been as strong with preventing injuries. I will say over time, we have seen a reduction of injuries. That's because we are learning some things. We now have booster seats. We wear seat belts. There's more helmet use. So when you put those things into perspective, we've seen some reduction. However, when it comes to percentage, we're not doing very well, and injuries are still the #1 cause of death to kids. Next slide. You know, C. Everett Koop, when he was a Surgeon General of the US, he said, if a disease were killing our children in the same proportion as injury, we'd be outraged, demand this killer be stopped. Can you imagine if we said 85% of teen deaths are the result of diabetes, like they are injury? People would go nuts and they want ways that we can prevent this. When it comes to injury prevention, we have a lot harder of a time of moving that needle. Next slide. So just some other numbers. In an average day, there are more than 80,000 injuries that result in hospitalization or death. About more than 25% are to kids. And there are more than 400 deaths due to injuries. And again, more than 50 are to kids every single day. Next slide. And if you want to look at, well, what are these injury deaths? Well, of course, they change with development and age. As you see, as kids get older, there's more of violent causes, so homicide, suicide, and unfortunately now we're seeing so much more firearm injury than we have in the past. It used to always be motor vehicle collisions, #1 cause of death. In Franklin County this past year, it was firearms that caused more deaths than anything else. So we're seeing those kind of increase. We also, in kids that are under 5 and the teenagers, drowning is a problem, as well as medications are a problem. Again, as I told you, things that happen very quickly or things with significant force are the ones we have to be most concerned about. Next slide. So I want you to start thinking of these as these are unintentional injuries that are 100% preventable. These aren't just accidents. In the old days, that's what people thought. These are accidents. What does an accident mean? Oops, just happens. We've all heard them saying, boys will be boys. There's nothing I can do about it. But there is. These are 100% preventable, especially ones that cause significant morbidity and mortality. So several Easters ago, a 4-year-old out on an Easter egg hunt, and the boys found floating in the family pond, and they try and resuscitate him. He's now trached, G-tubed. This was 100% preventable. It's not just an accident. Next slide. And then the last thing is, you know, we talk about the cost of healthcare. Well, if you look at injury accounts for close to 15% of all medical spending, all right? But what's really frustrating is Medicaid and government agencies paid for about 40% of days children spent in the hospital. So when we have organizations saying, well, wait, we shouldn't be able to mandate helmets on kids, or we shouldn't be able to mandate booster seats on children. Well, we're paying for these in the back end, and we're talking about, we're close to $15 billion. I mean, so this is something that we can cut healthcare costs and we could save lives and prevent these injuries. Next slide. So when I start thinking about like, how do we prevent injuries? I always think that we need to look at this in a sequential fashion. So first, what is the problem that we're hoping to solve? Who's at risk for that problem? What intervention are we going to put in place? And then we need to evaluate it. And it's really important that we look at each of these, because if you miss one of them, you can have a problem. So for example, if I wanted to reduce gun deaths in, let's say, Cincinnati, but there are only 2 gun deaths, well, maybe that's not the problem I need to solve. Or for example, every year we see about 30 kids that break their arm on playground equipment. If I knew where this playground was, we might find that 20 of the 30 at one playground, all we have to do is get rid of that playground. So knowing the data and seeing where the problem is enables you to develop an intervention. Next slide. Well, when we look at the types of interventions, a lot of times in injury prevention, we look at the 4 E's. So one is engineering technology. engineering and technology is one of the greatest ones to prevent injuries because a lot of these are passive approaches. It just happens. No one has to do an action to prevent it. So, for example, we used to see a lot of iron ingestions in younger children and toddlers because the parent would get iron, they would leave it open, it would be gummies, the kids would eat a ton of them, and then they'd end up with iron intoxication. Well, what did we do? Well, now they put iron individually packaged. So a child would have to punch out each one of those tablets. And since then, we have not seen an acute iron ingestion as a result. It's the same as Tylenol. When you get Tylenol in a small bottle with the safety closure, we have not seen an unintentional Tylenol ingestion in a toddler since we put those interventions into place. The other one is environmental changes. So bike lanes, window guards, traffic signals, and then enforcement legislation. It's been pretty well shown that you can almost double or a little more than double the use of helmets if a helmet law is placed. Now, I'm not going to spend a lot of time on these three interventions because if you're really interested, I'd love to talk to you more about getting involved with, if you're interested in legislation over injury prevention or working with your communities. I don't expect all of you to do that. But the one intervention, which I do think all of us need to do, is education. And when I talk about education, I'm talking about screening for modifiable risk and then educating families and patients about prevention. Next slide. One thing I hear all the time is it going to make a difference? Well, the literature is pretty clear. One, you'll be increasing knowledge if you educate families about injuries. So let's say you educate them, but they don't change their behavior. Well, at least you're now educating them and they're making decisions based on the right information. So increasing knowledge is really important. But we've also found that not only by educating will we increase knowledge, families do change their behavior, and there's literature on each of these that families have changed their behavior. And in response, by changing your behavior, we do see a reduction on injuries. So our counseling is effective and it works. Next slide. Well, why don't we do it? Okay, so one answer is, as I told you in residency, we're not well educated about it. There's a lot of literature to say that we don't counsel unless we received education on it ourselves. So since many of us might not know, oh, these are the injuries, these are the problems, or we feel it's overwhelming, there's too much to talk about, then a lot of times we just will give a handout or we avoid the conversation. Also, there's not enough time. So there in the mid-2000s, there was a study in pediatrics called Drowning in a Sea of Advice. I mean, there are over 192 health directives that we talk about 2/3 of these are injury. And if you take a look at the diagram, in the red is the accumulation of our discussions, and the bluish purple is the new additions. So we never take anything away. We just continue to add as we realize that problems are occurring. And then we don't get reimbursed for a lot of this talk. So when we don't have a lot of time, there's a lot to discuss. A lot of times we might not address it as readily. Next slide. What I find frustrating is this study that was done in mid-2000s. It talks about injury prevention counseling and behavior change. You can hit it again. So what they did was they looked at 1994 estimates on getting counseling on injury prevention at their office visit, and then they repeated this in 2007. Next slide. And what was really frustrating, which I found, was when they asked families, did you receive any topic on injury prevention counseling during your visit? In 1994, 39% said they did. In 2007, there was really no change. So this is on us. This is an us problem that we should be fixing. As pediatricians and healthcare providers, we're talking about the thing that causes the greatest morbidity and mortality, yet we have not changed our behaviors in counseling and educating families about the greatest risks of their child. Next slide. So in late 2000s, we at the Ohio AAP decided there has to be a better way to do this. And so what we did was we brought together a group of national injury experts people from National AAP. We looked at Ohio Department of Health stats, and then we looked at Bright Futures, tip sheets that we used to have, policy statements, and then we later added social determinants of health questions. Next slide. And the reason I want to share these statistics is just because it's pretty interesting. So when we started with kids under 1 year of age. We had 6 different well child visit tools. The reason why was because development changes, there were different injuries that we wanted to concentrate on. But if you take a look in the table here, pre-study, when we actually looked at what was discussed, less than 50% of the time was any injury prevention topic addressed with families. We put our tool into place, and close to 90% of the time was every injury prevention topic addressed. And the greatest things were, we weren't addressing supervision, water safety, which in kids under 1 year of age is a significant risk. And then we weren't addressing like outdoor play, those kind of things. And by putting a tool in, we increased it significantly. The other graph shows that when we put this tool into place, similar to what many of you are doing with the tools that you're receiving in your practices, they got this tool into place within 1 month, and it was sustained throughout the entire collaborative, which goes to show it's easy to use, simple to put into practice. And once you actually develop a system to put it into place, you can sustain it pretty readily. Next slide. So then in the next year, we said, okay, we have providers using the tool. Is it making a difference? So we followed families up after their initial visit, and we followed them at second visits. And what we found was in the birth to 4 month age, at least 50% made one change in their behavior based on counseling done by the physician. And in the 6 to 12 month, close to 2/3 made at least one change in behavior based on counseling they received from the physician. And I will tell you that most of the behavior changes were simple things. Check your hot water heater. Do you have a fire extinguisher? Do you have the poison center number next to your phone? So things that were easy to do was a lot easier to make the change. Things that were more difficult, such as you need to purchase a car seat or a booster seat, was a lot more difficult, and it took a lot more of a oomph. And we're going to talk a little bit more about that in the next couple slides. Next slide. And then the last thing is that, we're talking about education. It does make a difference. So if you take a look in the upper box where it says graphic representation, the majority of the time with intervention group versus control group, when you educate, the intervention group does make a difference. But look, if you add product with the education, you have significant difference. So it's always worthwhile to sit there and say, what am I going to do to give out products, or at least make products more available to families so that you can push the needle? A friend of mine opened a practice in Chicago, and they actually had like a pool behind their practice. They had no idea what to do with the pool. They received a significant number of grant funding. They put a tarp over it, and they filled it with car seats and booster seats. And they made sure that everyone that left their practice was properly fitted in a car seat and booster seat, because it was the #1 cause of death to kids. I'm not saying everyone has to do that intervention, but by giving out products, they made significant changes in the behavior of the families. Next slide. So in the next 5 minutes, I just want to talk a little bit about our techniques of educating. So many of you, if you're using our Injury Seek tool, we have found that you don't have to address every topic on injury prevention. For the most part, most families are practicing the appropriate behaviors. However, we do find close to 4 or 5 or 6 of the behaviors are not being practiced appropriately. Those are the ones that you want to address. So therefore, if you're using this tool, you actually are spending less time counseling, and you're actually spending more time counseling on what the exact needs are. So as I said, the first thing is we're finding, using a tool, what are the at-risk problems? And then we are educating them so that they are learning what is the appropriate behaviors. However, if they've heard that before, then how do we encourage them to change that behavior? Next slide. So I'm just going to go over, there's a couple models of health behavior change. The 2 main models I'm going to really address is the health belief model, and the trans theoretical model. The other models are like, for example, the theory of reasoned action. It really goes into the idea that I know that twice a year I need to change the batteries in my smoke alarm, and I want to do it. And when I see the alarm, I say, "Oh yeah, I have to go do it." But you get caught up in day-to-day routines, and so we have to find ways to overcome that. And the health belief model talks a little about that. That's why I'm only going to talk about that model. So next slide. So the health belief model, which is the oldest theory, it depends on 4 areas of perception: the susceptibility that injury is going to happen, the severity, the effectiveness of the intervention, and the cost of the intervention. All right. So as you can see, many people will say, you know what, I'm going to the store. It's around the corner from where I live. The chance of me having a collision is low. You know, I don't feel like putting on my seatbelt. So this is what's going on in their heads. And we have to give them the right education to let them know, you know what, the most common time for you to get into a collision is closest to your house. Those collisions can be just as severe as other collisions. You have to wear a seatbelt at all times. Your child should be in the proper restraint at all times. That might be your initial education. But then what are the next things that we can do? And the largest benefit is in self-efficacy. Give them examples. Find out where their problems are and help them with their specific models. Use role models and give feedback, and give clear-cut directives. Maybe the problem is they don't know where to get a seat. So I'm going to tell you where to get a seat. I'm going to write a prescription for you to get that seat. And next time I see you, I hope that that's done. Maybe it's they don't believe it's needed. So then you're going to spend time talking about what can we do to make you understand why it's important. So understanding what the needs are of that family and giving them clear objectives at that visit is very helpful. Next slide. And you might have to click through all these, Alex, but the trans theoretical model really just talks about how interested is the family in making that change. So for example, if you say, you know what, you really need to have your child have a 4-sided fence around your pool, they might say, I'm just not interested. And so then you can say, okay, and you can address that comment. They might say, well, I'm thinking about it. And so then you might want to challenge, well, why are you just thinking about it? Why isn't this a definite? They might say, well, I'll start soon. Cool, let me help you get started. Okay, go to the next slide. So I think that in our discussions, so we've talked about you're using a tool to screen, you're educating based on the best knowledge for the family, you're gauging their interest, and once you determine their interest, then you could put your discussion based on that interest. So for example, they're not ready for the change, maybe just raise some doubt. Say, you know what, you might want to consider and think about this. I'm going to talk to you next time you come to our office. They might say, I really don't know about it. Well, let's explore this change. Let's think a little bit more about it. And maybe they're ready. So if they're ready, let's make a plan. Let's come up with an action plan together. Next slide. So hopefully in this 20 minutes, I want you to understand that, think of your counseling approach. So first, use the right tools to screen in the clinical setting for risk. Because if you don't know what's a risk, it's hard to address it. And you just don't want to blanket address 2 or 3 things, because if they're already doing it, you're kind of not using your time wisely. Address the readiness. How readiness are they for this change? Are they just going to say, yes, I hear it, or they're not sure? For example, how many times have you talked to a family about safe sleep and they say, well, my mom says it's best for the child, or, well, I breastfeed, so therefore I want that child in the bed with me. Well, I understand that, but let's practice. Let's talk about this, and how ready are you to make that change? How can I get you to understand why it's important? Consider your counseling efforts. So how are you going to have these discussions? And then work with others to relieve some of these community barriers. You know, maybe there isn't a place to get car seats in your neighborhood. Maybe there's ways where you can work with communities to help your families. Next slide. I will say this, if you are going to spend any time on injury prevention, we at least know some things work. Helmets make a difference. Safety closures prevent poisonings. seat belts, airbags work, four-sided fencing for drowning, smoke detectors, window gates, stairway gates. These things work. So at least have families that we know things work, have them make sure that they're using these items. I mean, that's the least that you could do, but then also knowing where the risks are and understanding what their needs are is just as important. Next slide. So I know this was like a whirlwind tour. I was told I had about 20 minutes, but I really just wanted to touch home and say, look, injuries are a problem and we are not moving the needle, and we have to start to move that needle. And you might be able to do things in engineering and advocacy, but all of us that are seeing patients, we can make a change just by addressing it with our families. And just addressing one thing of like, I'm only going to address car seats, you are not addressing all the problems. And I will tell you, when you call a pediatrician from the ER and say, I'm sorry to tell you that your child died because they were sleeping with their mom and they died of SIDS, or they died of drowning and they didn't have a four-sided fence, it kills my heart every time that we had that ability to talk to them. So it is part of our jobs, and hopefully you can find some tools within the Ohio AAP to make this an easier practice for you. Next slide. So I will be happy to answer any kind of questions.
Thank you so much, Dr. Gittleman. And like he said, if we can open it up to questions, you can unmute, let Dr. Gittleman know if there's anything that you all would like to chat about. And thank you again, Dr. Gittleman, for presenting today.
Hi, this is Dr. Obeto. I have a quick question. I'm not sure if I missed it. So in terms of car seats, if we do see a family that needs a car seat, are there resources that will help them with getting a car seat?
Just to repeat the question, are you asking how to help families get car seats?
Yeah, like if they say they can't afford to get one, or we see a family who can't get a car seat, are there resources we could send them to?
Well, I mean, there are community resources that, like, I don't know what region you're in. Many of the children's hospitals have car seat check stations where families can go and get that done. So it really just depends on where you live.
Okay.
And ODH posted in the chat too that they have a car seat program, and Anna's gonna post it in the chat for us. And then Dr. Denny had also mentioned Ohio Buckles Buckeyes is a great resource. Are there any other questions?
Mike, can you elaborate a little bit on the Put a Lid on It program from Ohio AAP?
So our Put a Lid on program, I think it's in its 12th or 13th year. We give out about 10 to 12,000 bicycle helmets a year. The idea is that a lot of groups in communities have community events, and we want them to push kids wearing helmets. We just actually had our sticker event yesterday where we put stickers on all of the helmets. There's an application on the Ohio AAP website to, if your group is interested in getting some helmets, and it's a great way to get helmets to the community. I can tell you that we actually researched this in the first 5 years, and we found that in the communities where we were providing helmets, we did observations, and more kids were wearing helmets in the observed communities. So it really does make a difference to be able to, as we talked about, not only educating, but being able to give product to families.
Thank you. Are there any other questions?
Yeah, thanks, Mike. That was tremendous. And I think it really puts the challenge on all of us. I think I do a good job of bike helmets, but I probably don't talk about swimming. Do we have a link to the screening tool?
I don't have the link on me. I know that Haley Southworth has it, and you can look through the tool. I can tell you what's interesting is We've had some that have done our course, the QI program, and then we've had other physicians that have just looked at it and they've adapted it to fit their needs, the tool. But I will say we used a lot of questions based on how families are actually practicing. We never said something's right or wrong. It's really just a way for us to have discussions. So if a family, it says, I don't use my car seat all the time, well, that we should have a discussion about that. But it doesn't mean that they've done something wrong. We found out in the past, families don't want to think that they did something wrong because they're not doing something wrong. They just need a little bit of an oomph and education as to what some of the right things are doing. But yeah, I would encourage you to take a look at it and see what kind of things you can put into your daily practice.
Thank you, Dr. Karras. And I can send the screening tool out to you.
Yeah, we have that too. So yeah, we'll just get that out to everybody.
Great. Anything else? Are there any questions in general about screening tools or about the project, or any questions? Most of the advisors for the different screening areas are on the call now. So if there's any questions about any of the screening areas, feel free to ask now. I know I see, yes, I think they're all on. So I'm sure they'd be happy to answer any questions. If there aren't any, that's okay too.
Thanks very much, Mike. This was really good.
This is great. Thank you, Dr. Gittleman. Well, we will go ahead and wrap up then and give you all back your 15 minutes. Thank you again, Dr. Gittleman. Thank you, Dr. Bowling, and all our advisors for being here. And please let us know if there's any questions. And I will be in touch this week with your individual data.
Thank you.